Uh,
Ah, Dr. Sneha, I hope he's not gone, the one I did before.
it might.
Sorry, what did you say? Can you hear me? Hello?
We can hear you, Dr. John.
Okay. Okay, so I was talking about investigations. You do your ECG, your echo, then there are also other blood work you need to do. You can do, yeah, Holter monitor, but it may not um this may not be so immediate, but it's good to mention them. Then you need to do some other, maybe finger stick glucose to know this patient is suffering from hypoglycemia. Can also do a hemoglobin level if you're suspecting um maybe bleeding. They do a beta HCG for females of childbearing age. Can also go ahead and do your complete blood work, but of course you need to do the most important thing. You need to mention the most important things first. Let me say this. Let's say peradventure you get someone who is presenting with this and you're suspecting a cardiac cause, and they ask you what investigation would you like to do. Please don't rush to say I will do complete blood count, say make sure you are creatinine. Why they may be good, but that is not what they expect to hear at point in time. You've made your differential diagnosis. You're seeing this patient has red flags for possible cardiac causes. I'm not saying may not be able to do CBC and SUC alert. You can do them, but please start with the most targeted investigations. ECG, echo, Holter, whatever, you go straight. Then you can now say, I'll now have to do other this and this and that. It's very important. This says may seem as if it's nothing, but I think examiners pay good attention to them because they need to know that you're able to prioritize. Because remember, one of the things they do here, this is a publicly funded healthcare. So they don't want to waste money doing things that are not so relevant. I'm not saying it's not relevant, but as it relates to a particular case, try to go first with your bullets. Try to go first with the very big ammunitions you have before you go with the little ones. That's the point I'm trying to make. No, I just have a case. I would say before this case, uh, okay. I know this class basically is an is a narcotic class. However, I think I have two or three MCQs just to see if to use and drive home what we've been able to talk about, so you'll be able to rule in and rule out. Because the concept or the basis of taking histories, you're able to crack the particular presenting complaint, and you're able to rule in or rule out two or three differential diagnosis. Then the management, and which includes investigation and management, is already there with you. But at least you need to first of all to have a good interaction with the patient. But eventually you need to explain to either your patient or the examiner what you're talking about. So I just have about a couple, two or three MCQ options. Then we can look at. I think I can. I'll give someone a case of syncope and see how we do with that. Then yeah, I think everybody should be seeing my screen, I guess. So if you can just quickly do this, let me take this off so that's okay. Let's quickly do this. Should I go ahead? A 24-year-old collapses while playing basketball. He has no prodromal symptoms and bystanders reports brief shaking of his extremities. He regains consciousness within a minute, feeling well but fatigued. He has a family history significant for a brother who died suddenly at 20 years of age. So, which of the following is the most likely cause of this? Hypertrophic cardiomyopathy, epilepsy, vasovagal syncope, orthostatic hypotension. Go ahead, Goshran.
It's option A, hypertrophic cardiomyopathy.
Okay. Do you have any objection? Okay. Thank you. Yeah, you're right. During exertion, syncope during exertion, especially with a family history of sudden cardiac death, is a classic presentation of hypertrophic cardiomyopathy, which can cause left ventricular outflow, tract obstruction, and arrhythmias. Good. Next one. 78. History of hypertension and Parkinson's disease. Presents with recurrent dizziness and two recent syncopal episodes, usually occurring when he gets out of bed in the morning. Which diagnostic maneuver is mandatory to confirm? Go ahead, Gishran.
Option C.
Okay. Any objection? Okay. Thank you for that. A 30-year-old Asian male presents for evaluation after a syncopal episode. He's asymptomatic. Resting ECG shows right bundle branch block pattern with cove type ST segment. In ST segment elevation in V1 and 2. What is the most likely diagnosis? Can anyone help us? You can unmute yourself and say something, please. Okay,
It
Goshuan.
looks, yeah, it looks like Brugada syndrome.
Yes, Brugada syndrome. Yeah. Anyone with objection? And what gives it away is this coved ST segment elevation. Coved ST segment elevation. Okay, see how this case went. Now, they didn't give us a history of any family history, any previous family history of sudden death, but they gave a clinical observation, coved ST segment elevation. That's impressive. A 65-year-old comes to emergency after syncopal episode. Which of the following findings on initial evaluation would necessitate immediate admission and continuous cardiac monitoring? Yeah, Gushan, go ahead.
Option A.
Option A. Any objection? Okay, thank you. I think the last one off. So, um, a 405 experiences a syncopal episode due to newly diagnosed sustained VT, successfully treated with an implantable ICD. According to typical medical guidelines, what advice would you provide regarding driving? Okay. I see people are putting in answers in the chat box. Okay. Yeah, I'm seeing A's. Okay. Thank you. Okay. Okay. Now, I have a case that seems though like that we could treat as a narcotic. You're a physician. I would like someone to please see if you can attempt this case. You're a physician in the ER when a 75 years old presents with an episode of LOC. Take a history and discuss. Maybe just take a history. Yeah, let's just do history taking. That's what we're doing today. Okay, Petra, you want to try? Go ahead. Okay, let's do it this way because the way I did it, I just explored the questions you're supposed to ask basically. Then I can simulate another case of my own. We'll finish the class. So Petra, let me say you thank you for indicating interest to try this. So but let me just run this down, then finish up the CVS. Then I can bring up a case on Syncope for us to discuss. I'll simulate a case, I'll be the patient and you take history. I can do that. So let's assume, let's just do this generally for us, so that here for those who are just joining us, so that they will get a hand of what we discussed before. So, like I said earlier on, you explored the presenting complaints, the onset, the cause, and the duration. So, prior to this event, you want to ask this patient what happened before you felt like this. Can you tell me anything you remember that could have triggered it? You ask of triggers. Did they have any visual changes, any headaches, any nausea, any vomiting? You know, you might ask one or two of these if the patient is not willing to give information, but you can just ask what happened before then. They can just go ahead to tell you because of time. So during the event, you want to explore how long it lasted. Was there any motor symptoms, any tongue biting, bowel movement, or urinary loss? So was anything given to you before you recovered, or did you recover fully on your own? Then after the event, did you sustain any injuries? Very head injuries is very important. Did you sustain any injury? Did you fall? Did you hit yourself anywhere? So how do you feel after that? Do you still feel energetic, or do you still feel drowsy, or do you still feel tired? Then after that, you explore the associations that you have not covered in the things you've ruled out. Any chest pain, any shortness of breath, any palpitations. Have you had this episode before? Have you had this kind of experience before? Has this happened to you before? Then you ask your patients, what do you think could have caused it? What is your concern? What are you concerned about? What are you worried about? Then what do you expect at the end of this consultation? Now, let's assume you've done all this and you've not gotten what you think is most probably the cause of this. There is still past medical and surgical history. You want to ask this patient what is your medical condition? Do you have any medical condition for which you're being managed? So, if this patient is being managed for high blood pressure. You now want to go into medications. What medications are you taking? You want to probe further because there could have been a cause. Any surgical history? What about family history? Is there any family history of death, early death? Any family history of cardiac diseases? And also social history. These are things to explore, just like normal history. But at every point in time, you must have been seen to look out the possible risk factors that could have caused this particular condition for this patient. Cardiovascular examination. This is as simple as it is. It's as clear as it is. Though it may be a bit dicey, but it's all the same cardiac examination, I'll just encourage you to be as systematic as possible. Now, there are many schools of thought about how to go about it, about how to go with the cardiovascular examination. But what I want to say is be as systematic as you can. It is still the same normal inspection, palpation, auscultation, but how do you do it? from where to where. Do it in a way that someone who is observing, someone who is watching you could easily follow, could easily understand what you're doing and will not be confused in a way. So you sanitize your hand. Once you go into the room, you sanitize your hand, you introduce yourself, and explain the exam and the process to the patient. Very, very important. You don't just sanitize. Some people may forget to sanitize their hand and just go straight. Try to sanitize your hand. And when you finish doing that, introduce yourself. Introduce yourself. Tell the patient, I am so and so. Whatever thing they've given you as a prompt. I am Dr. John, and I'm the doctor in clinic today. So please, could you kindly confirm your name? Assuming you're just going straight for examination, you confirm your patient. It's very important you confirm your patient. Then you explain what you want to do. Explain what you want to do. I am going to carry out a cardiovascular examination on you. This will entail, explain in details. If you're going to touch this person, let the person know you're going to touch this person. If you're going to look at this patient, let the patient know I'm going to look at you. If you're going to expose this patient to any point, let this patient know. You need to explain the kind of test you're going to do, examination you're going to do, and obtain your consent. This examination is going to entail me taking a look at you. It's also going to tell me to expose the part of your upper chest, and then I will use my hand to perform some clinical maneuvers. Is that okay? On you. They need to know you're going to touch them. They need to know you're going to expose them. And they need to know you're going to take a look at them. So if it's okay by them, they'll tell you yes. They'll obtain consent, you go ahead. It's very important. There is marks for this. It's very important. Then you position the patient by setting the examination bed at 45-degree angle for optimal JVP assessment. Or I would just say that's just cardiac angle. Position the patient at cardiac angle. Then you go ahead to expose the chest properly. Also respect the patient's privacy by using a drip. Usually, MCC said they always provide a drip, so you can just to cover the patient and respect their privacy. Then as when you finish as you're doing this, and again, what most people, it's also always very good to request for vitals. I've said it most times. In exams, it's usually a garbage in, garbage out. It's what you give that you get. What you ask for is what you get. If you go to see a patient and you don't ask for vitals, the nurse is not going to give you the vitals. The examiner is not going to give you the vitals. Whoever is your chaperone is not going to give you the vitals. You need to ask for vitals. So you can make a quick observation on the ABC. By ABC, I mean patient is seated, is lying comfortably well, breathing spontaneously, is active, is alert. Because if this patient is on oxygen, you need to say it. If this patient is on NG tube, you need to say it. If this patient is on any device, you need to mention it. So if the patient is alert, active, breathing spontaneously, you mention it. So that is a good observation of it as a doctor. Then you comment on the vital signs. You say you want to have the vital signs of your patient. They give it to you. You comment on it. You must say something on it. Even if it's normal, the BP is this, which is normal. The temperature is this, which is normal. The posture is. You need to mention it. Then you go to quick inspection. You do a quick general inspection. Now, this is where I say it gets dicey. Most people will say you start inspection, you start with the hand. Some others will say you go to the foot of the foot because this is cardiac. That is why people practice it in many ways. I'm gonna just tell you what I think you could do, but like I said, well, no matter what you choose to do, just be systematic about it. So you don't go up, come down, go to the middle again, and start running around. Even you get confused. The patient, you get confused. Your examiner will get confused. So generally, I would just say go for a very quick general inspection if you have the time. This is usually paraventure if you have 11 minutes to do a full examination. Excuse me. If you don't have 11 minutes to do a full examination, you may not need to be doing a general physical examination. You just go straight to cardiac inspection. That's what I would suggest. I would advise you if your station says you have 11 minutes to do a CVS, then you have all the time. But if your session does not give you that 11 minutes to finish all the examination, maybe it says 11 minutes to take history and examine, then you know what you're going to do is a focused examination. So once you get in there, you just do focused cardiovascular examination. So, but let's just talk about on a general note. You do a general inspection, looking for any signs of underlying pathology. Does this patient is this patient cyanosis? Is there shortness of breath? Is there pallor? And also for any medical equipment, if you see an oxygen cylinder there, comment on it. If you see a walking stick by the patient's bed, comment on it. If you see a suction tube or machine, comment on it. Just say what you see. Then for me, like I said, I like to go in a very systematic way. I like to start from the head to the toe. Of course, your general inspection, you go to the, you have to start that from the foot of the bed. Assume you want to do a quick general, you just start from the foot of the bed, not when you're doing a focused examination. Let's be guided. If you want to do a general examination, normally on inspection, you go to the foot of the bed and do your normal showmanship. You bend down, you stoop, you look, you come up, and all that. It's normal. That is medicine for you and all that. But when the time is against you, you just go with pim ABC. You do what you want. You do what you're doing and move on. So look at the face for conjunctival pallor. Now, because you're still on inspection here. That's another dicey part. Some people may say go and pull down yourself, but I would just encourage you if you can, just ask the patient, please, can you pull your eyes for me? If you want the patient to pull it down or up, just give the command, please, can you pull your so push is also part of the thing you're going to tell the patient when you're explaining the test. I'm going to be asking you to be doing some kind things, or I'm going to be giving you some instructions. These are all part of the examination. I'm going to be taking a look at you. I'll be asking you to carry out some instructions, and I will use my hand to carry out some clinical maneuvers or clinical examinations on you. And they'll understand. So that when you not tell them, please pull down your ear or pull up your ear or your eyes, they will not say, oh, you didn't tell me that was going to happen. So you look out for central cyanosis, go to the mouth, any stomatitis. As you're done with the face, you go for JVP at the neck. You see, just coming down caudally from the face to the neck, and then you take a look at the chest. Look out for scars, any chest wall deformity, pulsation, any tube insertions. Look by the sides. Sometimes there may be there may be some whatever, maybe tape or whatever tube by the sides of the thorax. So it's good you also look at the side of the thorax. Don't miss anywhere. Don't just look at the chest wall, at the anterior chest wall and say, look behind, beside it. Then you also take a look at the hands for finger clubbing, for tile stainings, xanthomata, color change. And please, as you're looking, say what you are looking for. That's why I took time to itemize some of these things. Possible things you can mention on any of these parts of the body. The chest, the hands, the face. Say what you're looking for. As you're at the face, say I'm checking for conjunctival pallor, checking for corneal arcus, xanthelasma. As you're checking, you report. The dicey thing about examination is that you're doing three things at the same time. Listen, pay attention. You are doing three things at the same time. You are carrying out the instruction and the task, which is the examination, you and the patient, because you also give patient instruction. As you're carrying that instruction out, you are saying what you are doing. As you are saying what you're doing, you are also reporting to the examiner. So, because there's no time for you to come and finish the examination and turn to the examiner and start reporting. No, there is no time for that. You are doing three things at the same time. I'm checking the face for conjunctival pallor, non-present, non-appreciated. Do you understand? If it is there, you say, fine, it's not, of course, whatever patient they're going to give you, usually MCC will give you a normal patient who has no problems. But then they will now be able to give you the diseased condition. Let's say I'm looking for conjunctival pallor. If the patient has conjunctival pallor, your exam will tell you present, conjunctival pallor present. You say thank you and move on. If your examiner, he or she does not tell you is present, you say there is no conjunctival pallor appreciated or not present. So, but you must mention. If you don't mention it, let's say for example, now you say you're looking for you check the face for pallor, but you did not mention it, and that patient, but from the examiner standard, has pallor. Nobody's going to tell you that. They will not tell you. So you must be able to say what you're looking for. Then they will not tell you whether it's there or not. If it's not there, you go ahead. You say not present and move on to the next one. So that's why I took my time to itemize some of the possible things you could be looking for in this CVS. For the chest, you say I'm looking for scars, chest wall, any chest wall deformity, positions, any tube insertions. You look at the sites. If any of them is there, they will tell you. You look at the hands, checking for finger clubbing, for task staining, xanthomata, color change, splinter hemorrhages, John lesions, koilonychia, hand temperatures, and capillary refill time. These are things you are going to look out for in the hands. So if any of them is there as I'm mentioning it, the examiner will tell you is there. If the examiner will tell you is there, then you know it's not there, you say not present. Then you look at you can just do a very sharp glance at the legs for edema. Now you see how I did the inspection from head to toe because I'm doing a very quick a very targeted cardiovascular examination. But if I wanted to do a general one, like I said, that was what I said here. A quick general one, you start from the bed, from the foot bed of the head, from the foot toe, sorry, from the foot bed. Do your inspection and move on. Do your showmanship, bend down, squat, look, and all that. Okay, so palpation. Um, yeah. So most people, some schools of thought will still put it out there that inspection starts with the hand because from under that inspection, they will now start doing the radial pulse, rate, rhythm, and all that. But for me, I think it's wrong. No, I won't say it's wrong, but I just don't fancy it because if you're doing inspection, palpation, or auscultation, and now you're doing inspection of the hand, and then all of a sudden you're now palpating, and after you now go to the face again and start inspecting, come to the chest and start inspecting, it's just clumsy. For me, I think it's clumsy. If I'm your examiner, I just think, hey man, I don't even know, you're just dancing around. So if you're gonna look, you look. If you Once you start touching, you started touching. So that's why I start to look from the head. I look at the head, I look at the neck, I look at the chest, I look at the hand, because from the hand I want to start talking. I want to start touching. So because for the face, I can tell my patient, please just help me pull up or pull down your eyes. I'll check what I want to check. Can you open your mouth a bit for me? You know, I look down, I bend down, I look very well. Okay. Please, can you turn your neck to that way for me? You turn your neck because I've already positioned you. You turn your neck. I check for JVP. None. Okay. I'm going to take a look at the chest wall now. I look at the chest wall. Please, can you move this way? Can you move this way? I look by the sides. Then I'm looking at the hand. Please, can you bring out your hands for me, please? Can you turn it back way? You do. So once you finish that, the next thing you're going to do is CR routine. Once you start your CR capillary review time, you have started touching. Once you do capillary review time, that's for me. You've ended the inspection and you have started touching. Once I do that, then I'm going for the radial pulse. I check for the rate, the rhythm, the volume. With the radial delay, any collapsing pulse, you've started touching. Then, well, you may palpate for brachial pulse. I don't think it's so much standard. You can omit or not if you want. It's your choice for the brachial pulse. Then offer to measure the blood pressure because at this time you're supposed to also measure the blood pressure, but most times they must have given it to you. But it's still okay. You just mention it. Then you like to measure the blood pressure in both hands, sitting and standing. You just mention it, and you're not gonna do it, but it's okay to mention. At least they'll know you know what you're doing. After that, then you move down to locate the apex bit and confirm its position, in the fifth intercostal space midclavicular line. Then after that, you assess for parasternal hips and the trios over the heart valves. Then you also after this is palpation now. I think you're done with palpation, the pulse rates, the BP, the apex beat, the parasternal hips, the trios. Palpation done, then you go to auscultation. You do your auscultate the heart valves. Now, in some other advanced cases, the parameters, if you're dealing with murmur, which I doubt you're going to deal with, yeah, there may be some maneuvers to accentuate the murmurs, describe them and locate them and all that, but I don't think it's necessary. So you just do the murmurs at the mitral valve, the tricuspid, the pulmonary, and the aortic valves. Auscultate them. Then at this point, your patient is still in cardiac position. So once you finish this auscultation, you just tell the patient to sit up a bit because you need to also do a posterior quick examination. Now, you could have done both inspection when you were doing the other one, but it means you're going to be disturbing your patient. Remember, as a doctor, one of your main calls is try to make your patient as comfortable as possible. So once the patient is lying down, it is expected that you should finish every examination you have to do in that patient's position before you ask the patient to change position again. Not after, not when the patient is lying down. You say turn back, then lie down again, stand up again. You're making it difficult for the patient, and your examiner will not be happy, and your patient will not be happy with you too. So all this while the patient has been in cardiac position. So when you finish, just tell, please, can you just sit up a bit? I want to take a look at your back. You do a quick inspection at the back for any scars or deformities. Then you prepare for sacral edema. If there is any, check for sacral edema. Just check. Most probably you won't see. Then you auscultate the posterior lung fields for any respiratory compromise for those who have cardiopulmonary issues. Then you explain to the patient that the examination is over. You thank them and you cover them. Very important. So I think that's basically that for examination. The next thing I would like to do is I would like us to take one or two cases. Um yeah, I must say this too for examination. There is no shortcut to these examinations aside from practice. In fact, not just these examinations alone, even the history taking, the OSCE presentations, there are no shortcuts to it except to practice. I would encourage, if it's possible, you can just get one or two persons, once in a while, you guys try it on yourselves. If you need a doll, if you need, maybe you could buy a dummy, or a teddy and just try it if you can't get someone. But it is good you practice it. You can watch YouTube videos as many times as you want. You can read as many times as you want. But if you do not practice it, especially for those of us who have been away from practice for a long time, if you do not practice it, you may find it a bit tardy, not impossible, but you may not just be so at home with it. I encourage you to practice it as much as you can. So at this point, I would like to get a case for I think the first person was am I right? Someone indicated interest in having a case prior to before now. It's like the person is no longer here. I'm looking for, is the person still here? Someone help me.
I think she dropped it.
Sorry? I
I
think
think,
it was supposed to be Petra, so I can't see
yeah,
Petra.
yeah, she.
Yeah, I can't see her. Okay. So I have I would like to give two cases for syncope if anyone is interested. So I'd like to give two cases for syncope. Um,
I'll take that, Dr. John.
okay, yeah, go Sharon, yeah. Thank you.
I can't see the screen. Like, are you sharing any case?
Sorry?
I can't see the screen.
Yeah, just one sec. Just one
Okay.
sec. I'm just gonna bring it up. Trying to get it up. I don't know. I think something is hanging somewhere. Just one sec. I don't know why I keep getting logged out. Okay. Are you there, Goshan?
I don't see the.
No, I'm not. I'm not showing the screen. I want to just give you a case. I'm back again. Um, if you can hear me, Goshan.
I can hear you, Dr. John.
Okay. A 26-year-old,
Mm-hmm. Okay.
Sadie Sanders, has come to the clinic with a history of loss of consciousness. So I'd like you to take my history. I'm actually the mother. So, uh,
23. So, Dr. John, can you?
can I do what? Hello? Hello?
Consciousness and we have.
Dr. We can hear Dr. on that there's some technical not able.
Hello? I don't know. I don't know whether it's network or so. I'm just so. I think it's logging me in or out.
Dr. Can you just read the case again? Is old boy
All right,
Sorry,
was
no,
Dr. Sonia. Dr. John is being disconnected for this meeting like 3 of times. So
I
it's
said
okay
that
then.
26
I'm
year
being
26 years old lady.
he's logging system. He is here, but we cannot hear him.
Can you hear me now?
I think he's muted.
I'm not muted.
Dr. John, could you hear us?
Yes, I'm hearing you, Sneha. I'm hearing you and I'm hearing Gushan. Can you hear me now?
Yeah.
Yes.
Okay, I'm saying I have brought my daughter, who is 26 years old, to the
Mm-hmm.
clinic where you are the physician on duty.
Mm-hmm.
And she's presenting with sudden loss of consciousness.
Okay. And Dr. John, do we have
Do you have what?
her vitals?
Her vitals.
Yeah.
Wow. Okay, you want to start the history with vitals? You just take history. I'm not saying you should
Okay.
do examination, just history. I'm
Okay.
not we're not doing that. We can't virtually do examination, but we can virtually take cases like history.
Oh,
So
okay. Understand.
just take history. I'm not asking you to
Oh,
examine.
I'm gonna start then.
Mm.
Okay. So I'm gonna knock the door 3 times. Hi there, I'm Dr. Gusharan. I'm one of the doctors on the floor, and my ID is 23045. And today, let me sanitize my hand. May I confirm your name and date of birth?
Okay, yeah, I'm here for my daughter. She's Sandy
Okay,
Sanders, and she's 26 years old.
okay. Thank you. And her name is Sandy.
Yes.
Okay, all right. So I believe she came in with kind of loss of consciousness. So I'm going to ask you a couple of questions for that. Um, so okay, like Sandy, if I ask questions from your mother.
Yes, please go ahead. My mother can be able to answer the questions, yes.
All right. So can you tell me a little bit about her losing consciousness? When did it happen?
Okay, doctor. She's been a bit unwell with cold for the past few days, but today has been a lot more drowsy and sweaty. I went to take her some lunch an hour ago, then I couldn't rouse her when I came back. That was why I had to call the ambulance.
Okay. Oh, I'm so sorry to hear about that. And do you know somebody witnessed like what happened that time, doing something, or she was standing, or she was taking rest?
Oh, I'm not really sure. Like I said, I wasn't around as at then. But she came to visit 5 days ago, like I said, and she had flu symptoms. So it's been
Mm-hmm.
cold all this while.
So, uh, Sandy, ask questions from her. That
Mm.
okay? Is it okay if I ask her like what felt?
Yeah, please go ahead. Like I know she felt drowsy and sweaty in the morning. That was what I could remember.
Okay. And did, so do you know she lost consciousness? For how long did she lose consciousness?
No, I'm not so sure for how long it lasted. But I mean, I came back. I just knew that by the time I was trying to rouse her, I couldn't wake her up. I just had to call the ambulance.
Okay, and she look pale or she has any color change? You looked at her.
Sorry, what did you say, doctor?
I said, she turned pale or did her color change any blue or
No, 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 no. Not, no, I couldn't observe that. I didn't see any of that, doctor.
Okay. And was there was it tongue biting or any blood coming from her tongue?
No, doctor.
No. Know that if she recovered instantly or she was confused after that.
No, doctor.
No. Okay. All right. Um. So you think about, was it anybody who witnessed her, like her sibling or anybody at home?
No, nobody was at home. I'm just the only one that stays at home. So she came to visit me, and I went out to get lunch before I could come back. She was already down. But like I said, before I left in the morning, she was feeling drowsy and sweaty. So that was the only thing I know that happened. And when I came back, then she was like this.
Okay. I'm so sorry to hear about that. Yeah,
Mm.
I'm going to ask you a couple of more questions and I'll be able to do examination and we'll do some investigations to find what's going on.
Okay, doctor.
Is it okay if I ask you a couple of more questions?
Yes, doctor, please go ahead.
Okay, and did she ever experience similar episodes before?
No? You mean, so did you say, what did it come again?
Did she ever experience episode before?
No, she hasn't collapsed or experienced any seizure like this before.
Okay, so this was her first episode.
Yes, doctor.
Oh, and did she tell you, did she experience any pain, any
No, doctor.
soreness,
She's
anything like
usually
that?
very normal and fit.
Okay, alright. And didn't complain of any palpitations, shortness of breath, chest
No,
pain
doctor.
after that? No? Okay. So, alright. So I'm going to ask regarding her past medical history. So, you know, is she having any medical health issues like heart disease or
Well,
blood
doctor,
issues?
she doesn't have heart disease, but she has Addison's disease.
Okay, has Addison's disease. And do you know when was she diagnosed with that?
Well, she's been with it since she was younger, and she's been on medications for it.
May I know what medication is she on?
Yeah, she's been taking steroid regularly.
Okay. And is she taking it every day?
Yeah, she takes it regularly as prescribed by the doctor.
Mm-hmm. Okay. And is there any other medication she?
No other medication that I'm aware of.
And is there any uh, history of she getting any surgery?
No, doctor, she has not had any surgeries.
Okay. And can you tell me? I'm gonna ask you a couple of questions regarding the family history. Do you know if anybody family has any history of sudden cardiac death or any inherited cardiac disease?
No, doctor.
No. Okay. Right. And is there uh, so how about her menstrual period? Is she having regular menstrual periods or
Yes, doctor. She said it's been regular, doctor.
okay? And any history of prolonged bleeding or bleeding?
No, doctor.
Okay, all right. And so now I'm going to ask you a couple of questions regarding her social history. So, does she know if she uh, uses alcohol or she smokes?
Um, well, young people, they may tell you something and they do another one, but I think I'm not,
Mm-hmm.
just to be fair, doctor, I'm not aware whether she
Oh,
smokes or drinks because
that's okay.
I've not caught her doing any of those, so I can't say.
Okay, that's okay. And do you know if she's taking any recreational drugs like cocaine, amphetamine?
Yeah, I remember when she was younger, I think when she was 17, and I know I did catch her smoking weed with her friends. Mm.
Okay. And do you know is she still using it?
I don't know if she's using now. I know I saw her when she was 17 doing that, but I can't say for now.
Okay. All right. So, and I just want to ask you a couple of questions regarding her general health. Can you tell me if she has any history of prolonged night sweats, weight loss, loss of appetite?
No, doctor, I'm not aware.
Okay. All right. So I'm done taking, and so I'm just gonna summarize my patients. What happened? So she is 23-year-old girl. She came in with a complaint of loss of consciousness and was currently suffering from viral illness before, and she was sweaty, cold, and she was drowsy,
Mm.
and most likely this is a syncope episode, but we are going to proceed with investigations, and we are going to find out what's going on.
Okay.
Okay, Dr. John.
Okay. Do you have any critics and any contributions from the house?
Dr. John, can you ask me question again?
I said, do you have any contributions from the house?
Okay. Anybody wants to add anything?
Okay. Thank you, Gushon, for taking the case. Um, like I keep on saying, we can only get better by practicing. I appreciate your questions and how you approached it. I think maybe, hey, are you hearing me?
Yeah, I hear
Okay,
you.
because I don't know if I've been logged out. I know maybe the network has not been fair. I know
No, no, I'm
somehow it
hearing
may
you.
have affected our performance.
Yeah, I
Um,
believe I just lost my enthusiasm before, so I don't know if
yeah,
that's
I
okay.
know it's not. So I know why I wanted to give, like I said, I want to give two cases. I want to give a case of a young person and a case of an elderly. Now, this case is dicier, but and that was why when we were trying to crack the history, the prior event, the event, and the post event, you were not getting anything right. Apart from the fact I
Yeah,
told you that she had excuse me, that she had flu-like symptoms and felt a bit drowsy and sweaty in the morning. You couldn't get any much thing.
yeah,
Now,
Dr. John, I was how do I get the history? I was confused,
sorry?
like I got so confused because I couldn't get any history. I couldn't get any
Yeah, that's what
points.
yes.
That's
Yeah.
why I just I
And
didn't.
I'm coming to that. That was why and that's what I always say. When you ask all the things you think you should ask, just continue going down. The history, the cause of this patient's problem is in the medical history. I told you she was diagnosed with Addison's disease and she's been taking steroid. Now, combine it with someone who has Addison's disease and has been having flu-like symptoms for the past 5 days. You know, when you're taking steroids, if you have Addison's, if you're taking steroids, it is recommended that you should increase the dose when you're sick, right? So it's because so maybe you would have asked me, did she increase the dose? And I would tell you maybe she didn't do that because this she has Addison's disease, like I told you, diagnosed when she was a teenager, younger. Now she's been on steroid, and for the past 5 days she's been sick. She could have been taking her steroids, but she may not have upped her dosages. So what she had is Addison's crisis. Yeah, I know it's a bit dicey, but that was why I wanted to present. I said we need to bring this case up. You know, I mean, it's a bit dicey, but it's clear too in a way. So what this patient has is Addison's disease. But like I always say, in MCCQ will sorry, Narcos yeah, MCC will always let you know. For me, I don't think it's really always 100% about the diagnosis. It's more about the interaction you've been able to create with your patient. I don't know if you guys have been put through history taking. When I talked about organizational history taking, organizational examination, I talked about it because it is good for whoever you're interrogating, whether the patient or your examiner, to know where you are at every point in time. I mean, it's not compulsory. I must follow you 100%, but I should be able to relate with your line of thought. I don't know the style you're using for your clerking, for history taking. But I think in Canada they do more on OCD, PQ, ROST. I think I've mentioned it before. Consent, duration, PQ, that is position, quality, and all that and all that. Now, in this case, you did your OCD and you did your prior consent, prior event, during event, and post event. Now, when you now got down after your eyes and past medical history, you were now sometimes you come and ask me medical history, then you go down to social history, you come back again to medical history, and you go down to social history again. Try to try to have a pattern. Try to have a pattern in past medical history. But simple. Does it have any medical condition for which he or she been managed? Once they say it, you're done with that. Then you go from to medication history. What medications are this person taking? You get it. Surgical history straight up. You don't finish medical history, go to social history, come back again to medical history, and go down to surgical history. Because I think was it in social after some you were asking me about bleeding also. I was now confused. I was trying to follow you. I was trying to understand the line of thought, and I couldn't get it. And when you make an examiner feel like that, he's lost, and he doesn't know how to, how to score you or how to go with you. So try to see, follow the thought. Like after your OCDPQ arrest you, the other one is IS, past medical and surgical history, medication history, which is drug history or whatever, including allergy. Also don't forget whether this patient is allergic to anything. What if probably she has eaten something she reacted to? You know, allergy is also important. Is there anything you know he or she is allergic to? Then family history of similar illness. In your family history, put it this way: is there any family history of similar illness? Then you cannot ask a family history of chronic conditions or chronic illness. Then you now go to the patient's social history. Social history, which where the patient's living condition, work, which is occupation, then smoking, drinking and all that. So I need you to have try to itemize how or the patterns and the questions you ask for each of the sections of the history, especially after your OCD PQRST, so that you don't go here, come back again, go there again. I don't know if I'm making sense.
Yeah, Dr. John.
Yeah, but it was
You have.
it was a good one. I like the way you taboo the body of the history, the prior, during, and after. You know,
Mm.
I mean, I know there was nothing there. I know there was nothing there to get.
Yeah, that was the point where I was like, oh God,
Yeah,
how do
I
I
know there was nothing.
understand what's happening?
That yeah, the thing was the body of the issue was in the medical history. It was in the past
Mhm.
medical in the medical history and medication history. That's where it was.
Yeah,
So, but
yeah.
thank you. I like that. That was a nice one.
but
Okay.
I couldn't
Let me
couldn't
see if
think
I can.
of Edison
Sorry?
crisis. Like I was saying, like I cannot think about Edisonian crisis. That
Crisis.
was
Yeah.
the point. Like I couldn't reach to that point of
Mm,
thinking. So I thought maybe, she got infection
mm,
or how it related to soup. I was
yeah. Like,
myself not sure. So sorry.
mm. Yeah, usually people with Addison's disease, they are usually told to double their glucocorticoid dose. Um, that's the hydrocortisone dose when they are sick. So they can remain their mineralocorticoid the same, but the hydrocortisone should increase when they are sick. So, like
Okay.
for this patient now, the most important thing is to give hydrocortisone injection, 100 milligram, then IV fluids. You resuscitate the
Mhm.
patient, then continue hydrocortisone 6 hourly until the patient is stable. So, I guess. Yeah. Mm. Okay, let's see. Okay, let me get one more case. Let me look for an elderly situation. Okay. So, who wants to take one more case for the road? An 80-year-old man who is presenting due to loss of consciousness. So, you'll be taking a collateral history from the son.
Dr. John, I have one question.
Okay.
For palpitations, how we are going to ask a layman, like patient, like, are we going to say like, did you
Come again. You
experience
say,
any?
how are you going to ask what?
How I'm going to ask about palpitations? Like, if I have a patient sitting in front of me, I need to ask, did you experience any palpitations? So should I direct ask about palpitations, or did you
Sorry.
experience your heart is beating?
Sorry. Did you say how you want to ask for palpitation?
Palpitations, yeah.
Okay, yeah. You just ask your person. You could ask straight like this. Do you think your heart is beating weird or do you think it's beating faster? Some people use the word weird, like my heart is just weird, beating is weird, or it's beating faster. Now, if they say yes, it's also good. If you want to be an excellent student, you can say, can you tap for me how it's beating? Like
Mm-hmm.
demonstrate. Some will say it's beating ba ba ba. Some will say ba 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 ba. So you want to know whether it's beating irregular, or regularly regular. Do you understand? But that one is you just want to demonstrate that you want to push up your grades. So do you think your heart is beating faster? If they say yes, you say, can you tap for me the pattern in which it's beating? Okay? You may not be able to get the irregular from there, but at least just say it if the person says yes. Does that make sense?
Yes, yes.
Mm. So I have an 80-year-old man who has come with who is presenting or who is being presented by the son for loss of consciousness. Okay.
John, Dr. K. going to do that.
Sorry?
Dr. Kefa is going to do raised hand.
Is anybody taking it?
Yeah, it's Dr. Kefa.